Should be live in a few seconds.
Just
And we
testing.
are
Can
live.
you hear me? I can't hear anything.
We can hear you.
Yes, we are officially live.
Good morning, everyone. I'd like to welcome all of you and all of our YouTube viewers to the November 17th group meeting of the Group Insurance Commission. I'm Vice Chair Bobby Kaplan, and I'll be chairing this meeting until our Chair Valerie Sullivan is able to join. With us today are the following commissioners: Designee Cassandra Roeder for ANF, Designee Rebecca Butler for DOI, Division of Insurance, Elizabeth Chavit, Adam Chapdelaine, Edward Toby Choate, Christy Kleinard, Jane Edmonds, Joseph Gentile, Patricia Jennings, Eileen McEnany, Melissa Murphy Rodriguez, Anna Seneko, Timothy Sullivan. Matt, I'll turn it over to you.
Thank you, Madam Chair. Thank you, members of the commission. Forgive me in advance. I've got a bit of a cold. If I sound nasal and occasionally cough, I'll try to take myself off sound. If we can move to the next slide and review the agenda. In addition to our normal routine matters, we have two primary items for today's agenda. We will hear from our colleagues at the Health Policy Commission and on their 2022 annual cost trends report. And we will have a presentation and vote regarding the procurement for our employee assistance program. So that is the agenda for today. As Bobby noted, as our vice chair noted, Chair Sullivan will join us a little bit later, hopefully in advance of the EAP discussion.
I'd like to mention that I forgot to mention that commissioners who are not able to be with us today are Tamara Davis and Josino Garand. Sorry about that. Are there any comments or edits to the minutes? If not, we have the minutes before us from October 20th, and I'll entertain a motion.
So moved.
Second.
Thank you. It's Jane Edmonds. And who seconded? I'm sorry.
It was Adam.
Adam, thanks. Okay, and now I'll turn it over to our general counsel, Andrew Stern, to call on each commissioner in attendance and ask them to respond with aye, nay, or abstain.
Thank you, Matt, Vice Chair. How do you vote?
Aye.
Designee Roeder,
Aye.
Designee Butler,
Aye.
Commissioner Shabbat,
Aye.
Commissioner Chapdelaine,
Yes.
Commissioner Choate,
Yes.
Commissioner Kleinard,
Aye.
Commissioner Edmonds,
Aye.
Commissioner Gentile,
Yes.
Commissioner Jennings,
Abstain, I wasn't present.
is Commissioner McEnany with us? Skip. Commissioner Senenko,
Aye.
Commissioner Sullivan.
Yes.
I will mention here that Commissioner Murphy Rodriguez was unable to join us today. She is not with us. The vote passes.
Matt will now give us his executive director's report.
Thank you, Madam Chair. I'll spend a little bit more time on this than I typically do as we're awaiting the arrival of our colleagues from the Health Policy Commission. So I want to start by sharing some really exciting news from our Deputy Executive Director, Erica Schiavelli. On October 24th, Erica welcomed her daughter, Mariana Olivia Schiavelli Long. We offer our heartfelt congratulations to Erica during this exciting time for her and her family. We have, as you would expect, taken all the necessary steps to make sure that Erica's responsibilities are covered during her maternity leave. So during this time, for anything you may have previously reached out to Erica for, you may contact our Chief of Staff, Emily Williams. So I want to thank my staff for filling in while Erica takes her well-deserved leave to spend time with her new daughter. So we're all thrilled for her. Secondly, I also want to congratulate two GIC employees who have been awarded the Commonwealth of Massachusetts 2022 citation for outstanding performance in recognition of their contributions to service to the Commonwealth. The first is Melissa George, who's a program coordinator 2 in the operations department. She was nominated for her outstanding service to members and willing to learn and assist others across all units of the operations department. And secondly, Min Dang, who's a mail clerk in the GIC mailroom, was nominated for his dependability and willingness to always help others when he sees a need, as well as his excellent attention to detail. We have relied on him and others in the mailroom for a variety of tasks in the office, especially while we're all working remote. Both Min and Melissa were nominated by fellow GIC colleagues, and it's a pleasure to acknowledge their work. So please join me in extending a hearty congratulations to these folks for their well-deserved acknowledgements of service. It is really a pleasure to have them both as members of the GIC team.
Congratulations to both of them. I just want to say it's great. It's terrific.
Thank you, Bobby. On the communications front, we've already begun internally preparing for our fiscal year 24 annual enrollment. An important first step, early step in this process is hosting our annual public information sessions, where members are invited to learn more about the GIC, where we're headed, and to engage directly with our staff. As we have in the past, this year, we plan to host 3 virtual sessions at different times of the day to allow members to choose which session best accommodates their schedules and their needs. So for our calendar 2023 sessions, we will hold them on January 24th at noon, January 24th at 6 p.m., and January 26th at 9 a.m. And we will, of course, be spending a good deal of time publicizing those well in advance of those sessions. So I would say, just as an aside, doing these sessions virtually, as we've talked a little bit about before, has transformed how we're able to interact with our members. As you know, we're making these important final decisions about plan design and rates for the coming year. We're able to inform them about these changes that are under consideration, our projected premium rate, but also respond to written questions in real time on a wide variety of topics. So we will be posting information about these sessions on our website very soon. And as I said, we'll continue to update you as we have more details to share. As always, we invite commissioners to join on these if your schedule permits. I will say lastly that given that this is not just a normal year, but a year in which changes will come as a result of various procurements, we are putting a great deal of thought into other ways, additional ways that we can inform and engage our members. And we look forward to sharing more information about that with you at a coming commission meeting. On the engagement front, we are continuing to meet with a variety of stakeholders now that the health benefit procurement has concluded. Met with legislative leadership, our partners in labor, those who represent our retirees at Mass Retirees, and many others. This has been an opportunity to brief them on the outcome of the medical procurement. And I can say that these conversations have been very well received, and we will continue this dialogue with all our interested stakeholders. Finally, our communications and operations team is wrapping up a 3-month campaign to promote our self-service member portal, My GIC link. As we've reported to you previously, over the last year, we've been rolling out this portal to all agencies that we work with and our retirees. This latest campaign is focused on GIC members that have, their agencies have already been provided access to the tool. Their staff have received invitations to register for the portal, but folks have not already done so. So the goal here is to do everything that we can to get as many members registered as possible by the end of the calendar year. That way we're prepared to use it in a more robust way in the spring annual enrollment as folks make their benefit choices, especially important this year with some of the changes that we've made through the health benefit procurement. So I'll pause there. That is a brief recap of the executive director's report. If folks have questions or comments.
Thank you, Matt, very much for that comprehensive report.
Thank you.
And I'm very, delighted that we're having those sessions in January, and hopefully there'll be a huge attendance. I know we had it last year, and looking forward to having at least that number join us this year. I now would like to introduce David Selfs, who is the Executive Director of the Health Policy Commission.
Madam Chair, I think we first want to take a brief look at the calendar.
Sorry.
That's all right.
Okay.
This will just take a brief moment. Of course, we have today, we have the 2 items I've already discussed. In December, we will have presentation on the first presentation about our projected aggregate annual premium increases for next year. We will also come to you with a recommendation for the PBM procurement. So that's a big one, in addition to the update on municipalities. We've also provided on the next slide a look ahead for the coming calendar year. As you can see, in January, we will discuss our plan design recommendation with the Commission. In February, we will report back to you about the public information sessions, and we'll have a vote on our plan design. And in March, vote on rates before we move on to our annual enrollment. So as you can see, the rest of the calendar, please remember that these items are subject to change, and we'll continue to update you as we adjust or make changes to the calendar. We will surely be adding and moving things over the coming months. Any questions on the calendar?
Okay, thank you, Matt.
All right.
Sorry.
Thank you, Bobby.
Now, I would like to introduce David Seltz, who is the Executive Director of the Health Policy Commission, to present his cost trends report.
Madam Chair, if I could just say a brief word before David starts. I want to
Certainly.
welcome David and David Auerbach and thank them for coming back before our commission once again. The 2022 report is a big one because it marks a decade now of HPC reporting these, submitting these reports. And I and many others have followed this work closely since the HPC's inception. In addition to the presentation, I highly recommend that commissioners read through the report itself. And I think you'll find that it's a thoughtful and highly sophisticated analysis, which is also very readable. In Massachusetts, we're really fortunate to have the resources and the talent of David's team to help us understand what's happening in the healthcare marketplace. Ultimately, the work they do helps policymakers and helps market participants, such as the GIC, to make more informed decisions. So I welcome David and thank them again for joining us.
Great. Well, good morning. Thank you, Director Vino. Thank you, Madam Chair, and through you to all the commissioners. It's great to be back with you again. We're making this kind of a little bit of an annual tradition, an ability for us to be able to come over and present some of our findings to you and just discuss some of these important trends in healthcare. And we just really appreciate it from the Health Policy Commission standpoint, as well as there really is just a lot of opportunity for alignment and for us to be able to advance our shared goals for affordable, high value, high quality healthcare in Massachusetts. So just a big thank you. And also through you, Director Vino, to Erica, congratulations on her welcome addition to the family. Very exciting. So for today, we plan to just share a selection of some of the key findings that are included both within our cost trends report, which Director Vino just described. But we also are just coming off of our annual cost trends hearings. So the annual cost trends hearings is our event every year where we call and bring together different stakeholders and healthcare leaders to discuss the challenges facing our healthcare system and to have a dialogue about opportunities. And so we just had this year's hearings about 2 weeks ago. And some of the findings that we'll present here today were from that hearing in order to tee up a bigger conversation. Before I turn it over to my colleague, Dr. David Auerbach, to go through some of these data findings, I did want to just take a moment to reflect, as Matt said. This is the 10-year anniversary of the Health Policy Commission. We actually just had our anniversary of our first board meeting was this week, all the way back in 2012 in Gardner Auditorium in the State House. And as we've been thinking about the 10 years of the HPC and the 10 years of the Commonwealth's cost containment strategy, this really was a year for some reflection. Reflection on areas where we've made progress, areas where we haven't made as much progress we'd like, and to be able to have the 10 years of incredible data, to be able to mine this data and analyze the data, to really understand what are some of the really persistent challenges that are facing our healthcare system. And as we looked at the data over these 10 years, we did see areas of really notable progress in terms of the Commonwealth's annual healthcare spending growth. Over these years, we were in most of the years, except for maybe one, below the comparable US growth rate. So our healthcare spending was growing more slowly than the country on average. And in many years, we were below the state's own healthcare cost growth benchmark, although not in all years. And yet, when we look across these areas and see the challenges that we're facing today, we identified a number of places where there really are persistent challenges to advancing affordability in Massachusetts. And just to kind of tick through them briefly, we at one identified that there continues to be excessive provider price growth and extensive variation in provider pricing that is unrelated to value. We've seen increased market consolidation and a shift in patient volume to higher cost settings of care. We continue to see high and rising non-transparent pharmaceutical pricing, which may not reflect the value of those drugs and innovations. We see, especially in the employer-sponsored space, steadily increasing health insurance premiums, deductibles, and cost sharing. We've seen a stalled uptake of value-based payment models, and underlying all of this, it continues to be systemic and persistent disparities in healthcare access, affordability, and outcomes. And so, reflecting on these challenges, we did put forward a set of recommendations, policy recommendations this year, that we hope to be able to work with the new administration to advance in the coming year, to be able to address some of these persistent challenges. One final note, just on the cost trends hearings 2 weeks ago, I think it was a really incredible and important dialogue. We had leaders of our major healthcare systems who were reflecting on the really challenging time that they're facing right now in terms of staffing challenges, capacity challenges, challenges of just throughput through the entire healthcare system. And there was another example of this in today's Boston Globe, reflecting on just the challenges of moving patients to the appropriate settings of care throughout the kind of healthcare continuum, and facing real inflationary challenges and staffing challenges, and those are real. And we heard from the healthcare system leaders how difficult the current environment is. And at the same time, we also had a panel where we heard from consumers and patient advocates and employers about the challenges that they're facing when it comes to the affordability of healthcare, and how the lack of affordability in healthcare is leading to real access challenges for residents in the Commonwealth. There was a survey last year that almost 50% of Massachusetts adults said that they had foregone necessary care due to the cost of care. So how do we balance these challenges that are facing our healthcare system and our residents and plot a path forward? And that was really a theme of the conversation, and I suspect a theme that will continue today and then into the next year as we all look together to find common solutions. So with all of that as a very long preamble, let's look at some data, and we want to show you some of the trends that we're watching most closely. And as always, please, commissioners and staff, feel free to just interrupt, raise your hand, and if you have questions along the way. But I am happy to turn it over to Dr. David Auerbach, who leads our research team, to walk through some of these key findings that we're keeping track of. Next slide. And David, over to you.
Okay, thank you. Yeah, let's walk through some data, and please feel free to ask questions at any point throughout. As David said, some of this is from the cost trends report. Some of this is outside of that and even updated to the minute. In some cases, we have really some great, very recent data, but we'll do our best. Okay. So first, we're going to talk about some spending and pricing trends over the last several years. Okay, next slide, please. Are you controlling them, David, or somebody? Okay. Okay, so as David referenced, this is our commercial trend statewide. This is annual growth in commercial healthcare spending in Massachusetts compared to the U.S. overall. And you can see what David was talking about, where since 2013, our trend has been below the U.S. trend. Previously we were much higher in general, but you also see that gap, that sort of differential shrinking over time. And 2020 is a weird year, but it does seem like we have somewhat converged in recent years. Okay, next slide. another way to look at that, where we're dividing that commercial growth trend into prices and utilization. And there are some other factors such as service mix that are left out here, but this is kind of taking that trend from one of the larger insurers in the state over the last 5 years. And from their breakdown, they're finding that the unit cost in the orange is really dominating the overall spending trend, and that price, that unit cost, has been growing increasingly year after year over the last several years. And you see the very unusual utilization drop in 2020 and then the return in 2021. And so that leads to a 2021 trend. I think you know this already in your data, that the 2021 growth was quite high. Okay, next slide. We can look at the 2021 growth. We also have data from Medicare in Massachusetts. For the growth between 2019 and 20 is in the orange, and then 20 to 21 growth is in the yellow. And you see again that pattern of here we're able to divide it by broad category of care, and there's the drop in 2020 and then the increase in 2021 as things recovered. You see not as much of that in the hospital inpatient area, but more in the professional, where there was a strong bounce back in 2021. The blue bars are showing, if we smooth out the average annual growth from 1920 and 2021, the numbers look a bit more normal in a sense. And then you can see the prescription drugs, pretty high growth in both years for Medicare, with an 8.3% average growth in the 2 years. Okay, next slide. And so we spend the next couple of slides focusing on the prescription drug trend, and I know that is a big driver for the GIC as well. We've kind of broken that down in a few ways and used some outside data as well to reflect some of the trends. So prescription drug spending has been increasing as a share of all commercial spending. It was about 14.5% in 2013, and by 2020 it was up to 18.6%. Might be a little bit less than that in 2021, but it's going to be around there. That is a growing share. And it's really dominated by specialty drugs, a relatively small number of high cost products. The number of specialty prescriptions is similar from 16 to 21, but it's really the price of those, and they account for about 50% of total drug spending in 2021. Part of this is not just increases in price of existing drugs, but very high launch prices of new drugs. And a recent JAMA paper showed that those launch prices have increased in an enormous way over the last decade. Okay, next slide, please. And we have a few more on the prescription drug trend in Massachusetts. Here we're plotting out the average total price of a branded drug per prescription in Massachusetts. And that's been growing about 10-11% per year. That's gross. And you see the very long tail on the right. In 2020, that means that 5% of prescriptions were more than $4,500 per prescription. Next slide, please. And there's also a high amount of out-of-pocket spending that comes along with that total spend. That's on the next slide. Yeah. And here we identified several of the kind of common chronic disease categories where people are using a lot of drugs, a lot of branded drugs. And we see about 50% increase in out-of-pocket for people for a 30-day supply of these common drugs categories. Okay, next slide, please. Another really big driver of price growth. So you have prescription drugs, you also have hospitals. And as we know, a lot of that is from prices, is from the leverage that a lot of hospitals have, not all, but a lot of them do. One way we're tracking that here is the total commercial spending per hospital stay. So this is including price growth, it's including increased coding to get those into higher severity DRGs. And so all in, we were spending $14,000 per hospital stay in 2013, and by 2020, it's up over $20,000. And other indicators of, are the patients sicker? Not a whole lot. That's not really driving that trend. Other acuity indicators we look at, such as length of stay, don't show that much of a change over this time. And so keep in mind that 40% increase in spending per discharge. And then on the next slide, we're kind of putting that in the context of inflation and other things that might have been impacting the hospital's costs. So we all know that inflation has been has spiked recently, and that's in the conversation for sure. But it's helpful to keep in mind that from the 2013 to 2020 period, commercial spending per discharge increased 48%. So the hospitals were receiving 48% more revenue per discharge over that time, whereas the inflation over that time was pretty low. It was 13%, it was 15%. And so they were having a pretty large revenue increase, much higher than their costs would have increased, at least based on inflation. And the yellow is showing that revenue if you include all payers, commercial, Mass Health, Medicare. It's still quite a bit higher than inflation was over this broad time. Okay, next slide, please.
David, just before we move on, I did see that we had a question from Commissioner Evans.
Okay.
Well, it may be a side question, but I was kind of fixated on the chart that you had showing specialty drugs in particular. And I guess my question is, what if anything needs to be thought about in terms of different approaches to increase competition? I mean, in other words, I'm just a little concerned by the data, and admittedly, I'd like to understand more. But I'm just wondering, as a consumer, what does that mean to me and other people that we serve? And how do we know that there is really robust competition to hopefully drive those costs down, not upward?
Yeah, it's such a, I mean, I'm sure we could talk for an hour on that topic by itself. There's not a lot of competition. And do you want to make a comment, David? This is it's a difficult area because a lot of the tools are national, but there are things that the state can do and that we are recommending. Do you want to say anything about that, David?
Yeah, no, I just to highlight the point again, I think when, there's a need for some greater transparency, just baseline, to understand, when we see those trends in specialty drugs, how much of that is brand new drugs launching, right? How much of it is price increases on existing specialty drugs? And then how much of those, and what is the competition status, right? Are these brand new drugs that are launching that don't have a competitor, that do have a competitor? I think just at a baseline, and we've been trying to dig into this data. This is hard data to dig into, and some of it is purposefully kept confidential and opaque. But nonetheless, I think the overall trend is absolutely concerning, and one that I think we, have looked at closely. Some of our recommendations in this space, beyond just, kind of increasing our transparency and understanding of these drivers, has been to, there is a successful program right now through the state's Medicaid program, where they're able to negotiate directly with manufacturers on rebates for any drug, that serves their members. And if those negotiations fail, there's a process by which the Health Policy Commission could be charged with doing an independent review of how does the price compare to the actual clinical value of the therapeutic or the drug. We have not had to do one of those kind of value assessment reviews. But nonetheless, this has been a successful program for the Medicaid program, where they've been able to negotiate greater rebates and have, I think, over 100 million. I don't know the number off the top of my head, but a lot of millions of dollars in savings. And the governor and we have recommended that maybe we could build off of that model and have something similar in kind of the broader commercial space, not just in the Medicaid program, to say, what are ways that we can use independent data to understand, is this price justified? I mean, is this truly a life altering and saving?
Well, that's the point. David, I so appreciate your comments and also this presentation, because again, when I was looking at specialty drugs, I was saying to myself, what is a specialty drug? It almost sounds by definition that it's something that's sort of cosmetic or something that is not quote unquote necessary. And I said, but on the other hand, if specialty drug means it's treating people's chronic illnesses or serious illnesses. That's a whole nother conversation, I think. And so then the real question is, to me, related to what can we do? And you're saying transparency is critical, but what else can be done in terms of approaches to drive those costs down? And the only thing I can think of right now, and I need to know more and learn more, is competition. And all right, but I appreciate the response and the presentation. So I'll continue to.
And if I could just say one thing on that comment. So particularly as we talk about specialty drugs and you know, the definition of specialty drugs, to your point, Commissioner Edmonds, is a little squishy. It's sort of defined in different ways by different parties. But among the category are particularly the more expensive ones are biologics, right? And so, you know, there's been a long kind of slow running effort to increase competition for those biologics with companies that can produce biosimilars, and that you know, we're really on the cusp of starting to see some approved biosimilars come into the market, particularly for some of our most expensive and most used drugs. Humira is one that comes to mind that's always on the top of our spend list and other spend lists. We do expect biosimilars for Humira and for others actually to start to come onto the market as early as the coming year. So there's, those haven't come fast enough. And I think a lot of us would like to see that move more quickly. But that is, I think, one dynamic in the marketplace that, you know, makes me somewhat optimistic.
Thank you.
I see Anna, Commissioner Snako has a question.
Thank you so much. So this is really a wonderful presentation. I want to thank you guys, David and David, for coming, and the GIC for inviting you. I think this is really valuable. This hospital revenue per discharge chart is I don't know what the word is, alarming, amazing to see these data. And my question actually, David, I think this is average, right? Across all discharges. And so I just wondered, do you know anything about the variation in the inflation and hospital revenue per discharge across the state, across hospitals in the state or systems?
Yeah, that's a great question. In just a couple of slides, we'll show at least some of that hospital variation at a point in time. So in the levels of the prices, the variation is huge. We also would know underneath that the variation in the growth, and that would be pretty easy to share. I don't think the variation in the growth is on inpatient is as large. You know, I think the variation is fairly constant. All the boats have been rising and they've been maintaining their, big 2-to-1, but yeah, we could have more on that.
So the growth is similar. Yeah, that's interesting.
The growth
Thank
is
you.
similar, but I'll show, we do have in a couple of slides, we'll show that in the outpatient, the growth is a little more divergent. The higher levels are also growing faster, the high cost places. Yeah. Should I continue along, or is there?
I have a question.
Yes,
I just
please.
wanted to ask how this compares nationally. It's sort of, I'll echo Commissioner Sineko's comments. It's astounding, this information, and I really appreciate it. I know we all do. It's sort of astounding. The numbers just jump out there. It's scary, I would say, the increases. How do they compare nationally?
I think they're pretty similar. That my sense is the increases are pretty similar. That the underlying phenomenon of hospitals consolidating and flexing their market power to really extract higher and higher prices is a national phenomenon. It's happening everywhere, and there's not really a lot that insurers are able to do to negotiate those prices lower, at least for the must-have hospitals, the hospitals that are, you know, a larger presence that everybody wants to go to. It is a national phenomenon.
Thank you.
Yeah. Okay, let's do a couple more, and I'll try to go somewhat quickly. On the next slide, let's see. Okay. Here we're just focusing on growth over the last couple of years and contrasting that for office-based services, mostly professional physician services, and then your hospital outpatient, and then on the inpatient side. And, you know, keeping with that theme, the price growth is higher in the hospital setting than in the office setting. It's been about 4% per year for the last couple of years. And then on the next slide, we're getting to some of those levels, some of the variation. This is one of the more common commercial, or really throughout, one of the more common hospital stay categories: joint replacement, a hip or a knee, major surgery. And here you're looking at the average patient per hospital for this case, from left to right. So you can see that about $40,000 average payment for this surgery at MGH or the Brigham, down to about $20,000 for some of the lower price hospitals. And then I'm contrasting this with what Medicare would pay for the same exact procedure, same exact inpatient stay. Much lower. There is some variation in the Medicare side because of teaching and other factors, but in general, the commercial payments are often twice as high as the Medicare payments. Okay, and on the next slide, we'll compare prices for even something so common and simple as lab tests. Here we just constructed a set of 50 common lab tests and priced them at not only every hospital in the state, but also physician offices do these labs. Independent labs like Quest also perform the same lab tests. And you can see the blue bars are always a lot higher. Just the same labs, when you get them in a hospital outpatient setting, you're being charged a lot more for them. And almost everybody is way above the Medicare price for the same set of labs, which is that gray hashed line. And the cost sharing in the light blue, the cost sharing tends to follow the total price. And so the patients are paying much more just based on who is doing their labs. Okay, next slide. And this is the last one on this topic I was referring to before. We constructed an index for 50 common hospital outpatient services as well, and average those by hospital system. You can see variation for that set of services. These are colonoscopies, mammograms, lab tests, imaging, MRIs, ranging from about 19,000 for that basket of services to almost 30,000. And here you see the growth from 2018 to 20. The growth tends to be higher for the places with higher price levels on the right. That's that upward slope. So that here you do have some, the planets are moving farther away from each other, some increase in the variation over time. Okay, so that's the end of let's have the next slide, the end of some of the pricing trends. And I've summarized some of the key findings here. We all know about staffing shortages, and I won't get too far into that issue here today, but some of the price variation we've gone over and so on. Okay. Then we have a bunch of findings just on affordability, and let's just skim through some of those. These high prices, they lead to high premiums. The next slide is showing our commercial premium trend in Massachusetts over the last 20 years. Let's move to the next one. Yeah, great. Next slide, please. And family premiums, and this is probably fairly similar to what the GIC trend would be. Used to be $7,000, and now they're up above $22,000. And just to contrast that with the price of a new compact car, that has increased 9% over this time compared to the 202% increase in family health insurance premiums. Next slide, please. We see high increases in the merged market. These are the rate increases agreed to by the carriers and the DOI. And at the end of the day, Sometimes these are negotiated down or with higher deductibles and by plan choice, but these are the average rate increases, and they have been high the last 3 years. Not seemingly affected by the drop in spending in 2020. Okay, next slide. And one consequence of those higher premiums, although there aren't high deductibles within the GIC, but there is cost sharing. And with those higher premiums, people tend to, employers, individuals, they are facing a 10% increase in the next year. They'll do almost anything to keep that increase down. We don't want to continue to take all that money out of wages, and people go to higher deductibles or less generous benefit designs. And then we know that when that happens, people are more likely to avoid necessary care. They don't want to have that out-of-pocket consequence. Sometimes even just the uncertainty of it, people will avoid necessary care. And we see double the rates, especially if you're low income, when you have these high deductibles of avoiding care. Next slide. This is just showing kind of a sobering finding that when you divide up the state's population by income of their zip code and group those into deciles, you see that in the lowest income decile, 15% of folks had no medical expenditures entirely. You know, some people are probably healthy, but not that many. 15% had zero medical care, and there's a lot of care avoidance there. And you can see that trend by income. It's more of it on the lower income side. There are also access issues that are going on. Okay, next slide, please.
I think we have a question from Commissioner Kleiner.
Oh, yes, please.
Thank you. I'm just curious, how much is some of the price increase driven by the Medicare and Medicaid rates and other government, workers' comp, all those rates that are negotiated, that the other markets end up subsidizing because those reimbursement rates tend to be so low? I'm just curious, how, what you think about that. I'm curious if we're not seeing these huge increases because those other rates are so low, so the big hospitals have to make up the difference somewhere.
Yeah, that is a great question. And people have been kind of debating this for decades. And it used to be, I would say 10, 15 years ago, that was kind of a common story that folks told and felt was happening. And there could be some of that, but the research over the last 10 years or so has found that it's not really the predominant thing that happens. It's more that the hospitals, I'll pick on the hospitals, that this also is true in other settings. They really tend to negotiate for the highest rates they can with commercial insurers. And it's kind of regardless of what's happening on the Medicare side or the Mass Health side, they're not generally leaving money on the table. And then if Medicare or Mass Health would cut their rate, they'll say, well, I've got to scoop up that money back that I left on the table. They're generally getting the highest rates they can. And so they really are fairly unrelated phenomena. Now, what people find that does happen is that as hospitals are able to obtain higher prices, that they're nonprofits, they use that money and they often will expand. They'll buy new technology, they'll build more beds, they'll invest in staff, other things like that raise their costs. And while Medicare doesn't care that you've raised your costs, Medicare will be like, look, this is what I'm paying. It's going up 2% next year and so on. And so you end up in a place where the hospitals then are, quote, losing money on those Medicare admissions in some cases because they have allowed their costs to rise faster than the Medicare payments have risen. But that's not because of Medicare. That's just what happens at the end of the day. They're able to have their costs increase because of those high commercial prices they're getting, if that makes sense. It's a complicated phenomenon. I'm glad you asked the question. And that the narrative that you were framing that some people tell is not really supported by the research. Just leave it at that. Okay.
Great. Thank you very much.
Sure, let's move on. I think there's just a few more. I think we're going to the end of time. But a survey in 2021 also highlighted those affordability concerns that we see in the data, the same kind of things. Quite a lot of people say, yes, I am avoiding care, I'm skipping care because of the cost. And in some cases, those medical bills pile up and lead to catastrophic financial consequences. And there's just a general sense of worry about affording healthcare in the future, which makes sense. It is not surprising. Okay, next slide. We use the Massachusetts Health Insurance Survey to also dig into these care avoidance questions, and we find that care avoidance is higher if you're lower income, it's higher if you're Black, Hispanic, or other races, and it's especially higher if you have some physical difficulties such as a self-reported activity limitation. About a third avoiding care. And then we in the last slide, we boil a lot of that down together, those increases in premiums, increases in prices, and are adding that to other cost of living data from other sources to find that really at the end of the day, if you're living in the Boston area and between about 3 and 5 times the federal poverty level, which is where people roughly a middle class income, you're really challenged on being able to meet your basic expenses with health insurance premiums and out-of-pocket healthcare on top of a lot of other high costs. And this is a phenomenon I think we all know and feel. Okay. Is there, yes, one more question?
So yes, I just have a question, which the data is so disturbing, really, that what is it that we can do to make a difference, particularly, for people who are, who have a lower income or, who are, Black or Hispanic? I mean, what do we do to even try to make a difference? Because a lot of what's going on, and I read about it pretty much every day, the new pharmaceuticals that are being launched, that are like $200,000 for a particular drug, and the cost. It's so disturbing, and we know what's happening with MGH or MGB now, expanding and sort of what do we do to sort of make a difference? Is it that people are also avoiding, let's say, just going to the doctors, initially because they don't have annual visits because the cost is too expensive. It's only when people get really sick, right, that they go. And what can we do to, sort of interrupt these trends? Because it's getting worse. It's not getting better. And we all know about the staffing shortages, the lack of nurses. And so it's incredibly concerning.
If I may just interject, Vice Chair, your remarks are so spot on. I think in general, we have so many societal problems, world problems, nation problems, that the problems are of such large scale that as human beings, we say, what can we do that will really make a difference? And maybe as a suggestion, we could have a board, some time allowed for an agenda item for the board to talk about that question and bring the best ideas we can or the people into that conversation, but in the context of our proper role as commissioners. What can we do as commissioners? I'm sure that Matt and his staff are wrestling with these kinds of questions on a daily basis. So that's part of the conversation, but I echo your desire to try to turn our awareness into accountability and action.
Yeah, and before David, you respond to that, I'd just say that the HPC, in addition to doing all of this analysis, has been really the go-to source for ideas and strategies that policymakers and purchasers like the GIC can consider to address these trends. David, maybe you could speak to some of the high level, maybe top level recommendations that you've made about how we can all go forward to address this.
Yeah, and just to say thank you to the commissioner's comments. This is a huge challenge, and this is what motivates our entire agency is how do we address this. And we have some ideas and do think that there are ways where we can evolve our state's cost containment strategy. And many of these ideas are sourced from what other states are doing. So one of the, I think, great things about kind of state level health policy is that many states are really innovating and experimenting with different types of policy approaches. I mentioned that Massachusetts, we were the first state to have this concept of a healthcare cost growth benchmark. There are now 7 other states that have benchmarks in place inspired by what we've done here in Massachusetts that now collectively cover about 1 in 5 US residents. So we have this cohort of states that are all kind of wrestling with these same big questions and experimenting with different policy options. And at a very high level, we've put forward a set of policy recommendations in our report that are comprehensive and would be love to engage in further conversations on those at any date. But generally, what we see is an opportunity for kind of 3 things to happen at once. One is we do have this idea of a benchmark of being able to moderate the growth over time. And yet our accountability tools to really ensure that the marketplace takes the benchmark seriously are pretty limited. And so we think there are some opportunities to strengthen kind of within our existing structure accountability for individual health plans and health systems to make sure that they are working hard to moderate their spending growth over time. The second is really to take on provider pricing and pharmaceutical pricing more directly. There are states that have implemented price growth caps, still allowing prices to grow, but having some type of upper limit on those. And then finally, the health plans need to be a part of this conversation as well. And this goes to how do we ensure that if we're creating savings in the delivery of healthcare, that those savings are actually passed along to the people who are paying for it. And that goes to, how do we, look at savings being passed on to, lower deductibles, to lower cost sharing, and perhaps eliminate cost sharing on services that we know are really high value for patient health. And so, thinking of these things together, we do think that there are opportunities to kind of evolve our strategy. The last thing I'll just say here is just, I think there's an opportunity for state agencies to work together on these challenges as well. And so my offer of partnership and collaboration is always out there, and Director Vino has been so generous in wanting to connect with us and see how we can use our data to help you and vice versa. And I think that spirit of collaboration will continue.
Thank you, David. I really appreciate your comments and your offer of assistance. And I'm very curious if you know how many of our members, right, of the population that we serve have no spending, have zero spending. And if it's possible to drill down to see to look at the demographics of that population?
The answer is yes. I don't have that on my fingertips, but absolutely. One of the things we were able to kind of figure out, I think a few years ago, was to look at our data and to be able to isolate the GIC population and then compare the GIC population to maybe the broader employer sponsored commercial health space. And I think continuing to do that will help provide some insights. And so I'll put that on my to-do list. Very happy to.
That's great. Thank you very much.
David, so one of the 3 priority areas of focus that we have identified over the last several years, in addition to affordability and behavioral health, is health equity. And you've, I think, really, in a really compelling way, I kind of folded that consideration into the affordability challenge in that one slide. One of the things that so in addition to addressing affordability, we understand that by addressing affordability, we can address that affordability dimension of health equity. We also are participating with other state colleagues in the development of data standards to, in more granularity, understand the health equity challenges that we face specifically for our members. We know that will take time to develop, yet the urgency to address health equity challenges is really a today challenge, right? So we will use all of our tools to try to create better equity. We've used the procurement to gather commitments and specific strategies from our carriers going forward to close equity gaps, looking closely into maternal health as one example of that. We will look at our plan design. You mentioned the opportunity to incentivize high value services through changes in cost sharing. I think there's an opportunity to add a health equity dimension to that work as well. Can you speak to any of the other equity recommendations? We've talked a lot here about affordability as the focus, but there's really some excellent work that you all have done in the health equity space. Yeah. If there are any there that you would like to share with our commission that you think would be particularly relevant and salient for us to consider.
Yeah, thank you, Matt. And first of all, I commend you and the leadership here for pushing forward on using your levers as at the GIC to push equity into the conversation, into these procurements. You said something that I think really resonates with me, is that we absolutely need to enhance our data collection and the metrics that we're using. It is a must. If we can't look at the data to understand the problem, how are we going to solve it? And how are we going to know that we solved it? And how do we measure progress? It is critical. And there is, a lot of work being done across the state agencies and with health plans and others to push forward on that. But as you said, we can't wait on that to push forward. If we just, wait until we have the perfect data, it's too late. And this was a major theme at the cost trends hearings that we held 2 weeks ago, and was one of these areas where we did ask the health system leaders, what are areas that we can work on together? There may be areas where there is, agree to disagree, but are there areas of really common interest? And health equity was one that really came across every single person as an opportunity for this year, given the motivation and the urgency and just the energy in the environment. How do you harness that energy into making real change? I think of the things that you've mentioned, they're very well aligned with our recommendations around data collection, setting targets for improvements that can be measurable, kind of building off of what we've done with the benchmark, is to say, okay, let's put some stakes in the ground as a Commonwealth, as a state, to say, this is what we'd like to see 4 years from now. And then how do we get there? And then have the conversation about what needs to happen. The other area that we did highlight in our report this year was around payer-provider contracts? And are there greater opportunities for health plans to be able to put in contract incentives within their contracts with providers to not only incentivize, but help support providers in being able to dedicate resources to address these longstanding inequities? And we'll give a shout out to the Mass Health waiver that was recently agreed to, which does dedicate a significant portion of that funding to health equity kind of measurement and improvement. And so, kind of building off of that example, are there more that other commercial plans can do? And it sounds like you've been thinking about that, and the GIC's role through the procurement to say, what role do the health plans have themselves, but also how do the health plans work with providers to address these things as well? So I think really ripe topics for us to continue to work on.
Yeah, and we did see throughout the health plan procurement process in the bid responses a heavy focus on exactly what you just said, which is health plans working in collaboration with providers to meet needs, but also on data collection. I think there's a real opportunity there to build this into contracts. One of the things that I want to make sure that we do is boil down our strong commitment in this space to specific actions that we can, to your point, sort of track progress on, so that we're held accountable as staff to our commission. Our vendors are held accountable to us for their performance. And so, I think we have a lot to work with. I think we do have a big opportunity as the GIC, from the size of us as a purchaser, to help move the needle here. But boiling it down into a specific set of action plans, I think is where I think we want to make sure that we're aligned, right? Addressing health equity is to use the common phrase, it's all hands on deck. It's going to take real collaboration and alignment across the system, across all actors here. It'll be hard for any one actor to kind of move the needle alone. So thank you for your continued work on the health equity space, and we really eager to continue to work with you on that.
Agreed.
Other questions or comments from commissioners? Yeah, this is sobering. This whole presentation, very sobering, right? Sobering, startling, concerning. And I think, a lot of the trends that you've identified here are pre-COVID trends. And we know that they've only been made more of a challenge by COVID. We all have our collective work cut out for us in the years ahead. I just want to thank Director Seltz and Dr. Auerbach for once again sharing your excellent work with us, sharing your recommendations and your wisdom about what's happening. As I tell my commission quite a bit, we are subject at the GIC to the same underlying trends, and in some cases market dysfunctions, as all other actors in the healthcare space. What the HPC is uniquely able to do, uniquely positioned to do, is to look at it from a systems perspective, from a global systems perspective. And it's just an enormous asset to the Commonwealth, to us as an agency. And so we really look forward to continuing to work with you, David, and your team, and just thank you for coming here today.
Well, thank you, Matt, and thank you, Madam Chair. Always a really a great conversation, sobering conversation, but always really interesting. And I just look forward to this opportunity every year. And Perhaps next year we'll be in an in-person situation to be able to do this back again. And I just want to give one final shout out to one of the commissioners here today who also sits on the HPC board, pulling double duty. Thank you, Cassandra, for your leadership on all of these topics. So thank you all, and I hope you have a great rest of your meeting.
Madam Chair, may I make a brief comment?
Certainly. Jane.
I just want to, again, speak to you directly, David, when I listen to you, because again, awareness of these problems that we face, it's critical. And a lot of us don't have that deep awareness. But what I see in this conversation of Vice Chair Kaplan, and even in your remarks, is moving to the accountability. So what can we do, given our role, to make a difference now that we have that awareness? And I must tell you that for me personally, I just loved hearing you emphasize must have data in order to fix the problem and to solve the problem. As giant a problem as it may be, that has always been an absolute concern, that it's as if certain segments of our population are erased by not having the data. And I find that unconscionable, if not immoral. So thank you so much for today.
Thank you.
Thank you very much for your comments, Commissioner Edmonds. I'll echo everything that you've said. The information, David, the whole presentation is astounding. It's actually worse than I thought it was from, reading what's going on every single day regarding accessibility and affordability and health equity and all the disparities. And I'm thinking about our, the population that we serve. We have, over, I think, and correct me if I'm wrong, Matt, like over 420,000 people that we serve. And how do we sort of, at a very granular level, like at the bottom, how do we, help people who are avoiding, even dental care, which leads to very often medical care? What do we do to reach out to people and to, help them in some way, which, because a lot of this is very political, and a lot of this, are the lobbyists, right? That's a huge problem that we can't solve. But what can we do to help our members who, can't afford the medical care that they deserve, right? And that's available to them, but they just can't afford it. What can we do?
Yeah, it's a lot more work to do there for sure. As I look at this slide in particular, I am very cognizant of the fact that the members that we serve are public sector employees, and incomes for public sector employees don't keep pace with the private sector typically. And so if these are challenges across the state, these are most certainly challenges for us and our membership. One of the things that I'm proud to say that we've done over the last 5 years is to not proceed in the way that some private sector employers have, to one of the earlier slides, by cost shifting, by increasing copays and deductibles, and having an interest in high deductible health plans, which of course we said early on in our procurement process was not a direction that we were headed through this procurement. But that does increase when you do that, it manifests itself in increased premiums, and that is also a burden on our members and on the Commonwealth. So that comes at a cost. So we still have to address these underlying trends. Thank you for the comment, Bobby. Thank you, David and David, for joining us.
Thank you very much.
Thank you.
So I think we're ready to move on to our next
Sorry.
agenda item. It's okay.
Sorry, I'm still thinking about it. I apologize.
Good morning, Bobby. Good morning, commissioners. Good morning to the live stream public.
Oh, Valerie. Oh, thankfully you're here.
Hi, everyone.
I will turn this gladly. Hand you the gavel.
Thank you. Well, I am excited to hear more about the EAP program procurement. So I know the team has done an enormous amount of work, so I'll turn it over to Janine.
Thank you. Good morning, commissioners. Can we go to the next slide, please? So here on the slide, the strategic sourcing team is listed. We worked with the same people for this procurement and also for the EAP consultant procurement. We solicited participation from HRD, which has been helpful because they have been heavily utilized by HRD for critical incident response and workplace trainings. Next slide, please. So the EAP contract with Optum ends June 30th, 2023, and currently the GIC pays a fixed fee to administrate EAP services, which is based on an estimated 144,000 employee households. The most popular Mass for You benefits are associated with behavioral health, work-life balance, and on-site trainings. Next slide, please. So this slide details the process of this procurement. We received 3 bid responses, one from Optum, which is the incumbent, All One Health as well, and that's a Massachusetts-based company, and Deer Oaks, which is based out of Texas. And based on the initial scoring, all 3 were invited to interview. Next slide, please. So the scores are very close among the 3 bidders, and we did decide to award Optum 5 best value points for several reasons. Have proven capability to service the size of the Mass for You eligible population, and the other vendors do not have experience with a population that size. Optum also has the largest BH provider network, and there will be limited disruption for those utilizing EAP benefits, including BH services and substance abuse services. Optum is familiar with the Commonwealth's organizational structure, and they're also committed to improving other services, including cutting down turnaround time for communications, and their fees are very competitive. And since Optum is the incumbent, implementation fees are not needed. The decreased costs will allow for potential enhancements of the current services that are provided under the EAP program. And finally, Optum is the only bidder that's financially rated, which provides assurance to the GIC regarding their stability. So with that, the GIC strategic sourcing team recommends that Optum be the apparent successful bidder for the FY24 EAP vendor contract. Happy to take any questions.
I don't see a lot of questions.
I have some questions, actually.
But didn't see Bobby's hand until just now. So Bobby, go ahead.
Yes, thank you. So I first want to, congratulate Optum, because I know I've heard from many of our members who use the services that that they are very, pleased, very happy, often very grateful for the services that, Optum has provided, and sort of the guidance or the, I know that they provide a great benefit. So I'm very glad to see that they're going to continue in that manner. But I have a couple of questions regarding the number of their provider network. So do you know how that, what percentage or number of providers have increased? I know it's a constant problem, but I'm very curious, Janine, if you know how much, or if it's a particular area like the western part of the state, or do you know what, how they have increased their, or in what way they've increased their provider network, and the payment that they're, I don't know what, Medicare's payment is now, but I know that they were competitive with Medicare payments, but what's the situation right now? How do they compare to Medicare payments for behavioral health services? And I also wanted to ask about will they be providing 5 behavioral health visits at no cost to our members?
5 visits are a potential buy-up. So we would have to discuss that further, but it is an appealing option that they are willing to offer. With regard to the percentage of behavioral health providers, it's a national network. We also have Siegel on the line, and Lisa, I don't know if you can provide more insight into that.
Certainly. Good morning. Good question. In the BAFO process, Optum did indicate a 6 to 7% increase in the network over last year. Recruitment is a challenge for all EAP vendors at this time. And I would point out that of all the submissions, the 3 vendors, Optum's network is by far the largest network. So it was competitive. There are challenges in recruitment right now that are industry-wide. There's a migration to telehealth and virtual platforms for providing the core service behavioral health sessions. But Optum is demonstrating, a transition that's consumer friendly, and again, compared to the other submissions, I would say ahead of that curve. Keep in mind, this is currently a 3-session benefit, and the provider reimbursement does get negotiated sometimes regionally for the EAP services. So the comment about what the provider reimbursement is, it can vary.
Okay, thank you, Lisa.
Thank you very much. Thanks.
Bobby, do you still have more questions?
No, I don't. I'll lower my hand. Sorry.
Okay, great.
Valerie.
No problem. No, those are great questions. Hey, Toby, I see your hand is up.
Sure. Thank you for calling on me. Could somebody just give me a kind of brief synopsis of why we didn't choose All One Health? I'm reading the documents provided, but it's not real clear to me. I mean, if I'm reading them right, their points were lower. They were lower. Okay, no, not much. So if somebody could just lead me through the contrast of an Optum to All One, and Deer Oaks for that matter too, is just to kind of net out why that your recommendation was Optum, other than maybe it's just the points. I don't know.
Sure. After the BAFO, they came in at a lower cost, or the lowest cost. There's limited disruption with members who are currently using services under the Mass Review program. And And so we also have those options to buy up to enhance the program. And just the behavioral health network, those were some of the reasons why we awarded 5 extra points. Another factor is just the ability to handle a population size like the GIC's Mass Review eligible population.
Okay, so it's more of the size in the incumbency.
Right, if I could, oh, go ahead, Commissioner, sorry.
Go ahead, Jim.
Yeah, there were concerns with the other 2 vendors, although they seemed capable and gave strong responses that they would need to scale up, like literally need to scale up in order to meet our needs with our population. And there's a little bit of an implementation risk there, as you know, that's not a fatal thing, but it's something that we had to weigh. And as Janine said, the buy-ups with Optum and the lower price after the BAFO were both strong considerations, as well as their commitment to help us with communications with our underutilized agencies and populations, and to work with us and with those areas to try to improve utilization. We felt like they made a good faith and effort there to help us with those goals. Right? So it was all that. It was very close. And I should also say, in terms of context with that scoring, any scoring that's within that margin is really a virtual tie at that point. So then it comes down to the strategic sourcing team using best value points as the team sees fit. And there was a consensus on this one that this was the best way to go. But it was a close procurement, no doubt about it. I don't know if that helps.
Jim, is All-in-One or Deer Oaks any of them minority firms?
No, I don't believe so. They all scored similarly on the SDP scoring.
Yeah, well, that's important.
Yeah.
Okay, thank you.
You're welcome.
And just to add on to Toby's question, would you be able to comment on whether all 3 came in or did a virtual pitch session to the strategic sourcing team?
Yes, they all interviewed with the strategic sourcing team.
All right, great. I don't see any other questions, but the questions we had were really good. So appreciate the engagement by our commissioners. So at this point, seeing no other questions, I will entertain a motion to allow the GIC's procurement team to move forward with Optum as the successful bidder and start negotiations for EAP benefits beginning in fiscal 2024. Do I have a motion?
So moved.
Do I have a second?
Second.
All right, that was Joe on our second and Bobby on the first. So at this point, I will vote yay and pass it over to Andrew for a roll call.
Thank you. Vice Chair Kaplan,
A.
Designee Roeder,
Yay.
Designee Butler,
Yay.
Commissioner Shabbat,
Yay.
Commissioner Chapdelaine,
I think he had to step off.
okay. Commissioner Choate,
Yes.
Commissioner Kleinard,
Yes.
Commissioner Edmonds,
Aye.
Commissioner Gentile,
Yes.
Commissioner Jennings, Commissioner Jennings, you're on mute.
Yes.
Commissioner Sinenko
Yes.
and Commissioner Tim Sullivan.
Yes.
The motion passes unanimously.
Oh,
So I
that
just
is
want to,
great.
if I may, Madam Chair, I just want to
Sure.
thank the commission for the confidence to proceed with the procurement vote here. I want to thank especially Janine Dewar for leading and managing this procurement. She is, for your information, also leading the PBM procurement, which is underway right now. This is a heavy procurement season for us. This is Janine's first time managing this EAP procurement, and she's done an excellent job, and I want to thank the procurement team. So we have a lot more work to do with the vendor, a lot of work to do to make sure that we're doing all of our efforts to improve and increase usage and utilization of these needed services. So that's the work that once we're able to execute a contract on here, we will proceed to do. So thank you, commissioners.
Well, thank you, Matt, for those comments. Janine, I'd like to thank you for all of your hard work leading this procurement, and also the PBM one. We do know that's a pretty heavy lift, so thank you. So at this point, I don't think we have any other business on the agenda. I am looking for commissioners to see if they have topics to bring up, but I do not see.
You can go to the next slide, just for old or new business.
So if there are topics that we will be interested in discussing, we do have some time. I see Bobby's hand is up. Go ahead, Bobby.
Yep. I know I had asked David Seltz to provide information on the trends for our membership. So basically, the information that he provided on hospitals and on the number of people who, either go without medical care or who, spend very little or who can't afford to, all that information that he provided, I would like to see what actually the same information or the same data for our members, right? I think it would maybe help us to see, how we can assist people, what we can do, because the information is so disturbing that I sort of feel compelled that we have to, I don't know, work a little harder or do something different, or do more outreach. I don't know what we can do in our role, but I certainly would like to try, and I'd like to see that data if they are able to provide it. Not on everything he presented, but maybe there were about 4 slides that regarding the hospitalization and the pharmaceutical spending and the accessibility, and what that means for our members, like who's avoiding care altogether, and what that means regarding people who are at the lower end of the scale, including the retirees who, have many of whom have very small pensions and aren't eligible for Social Security. And that's also, I would like to, have that information.
So
Thank you.
Bobby, oh, go ahead,
Yes,
Ben.
Valerie.
No,
Yes.
thank you, Madam Vice Chair. We can certainly follow up with David and his team to see if the data that they used for those particular analyses would allow for a breakout of GIC members. I will say, we've got our own data analytics team as well that's doing some phenomenal work. And so between those two, we can certainly see what kind of analysis we can bring back to the commission.
That would be great. And I didn't mean to exclude, the GIC team at all. I just would like to see that information wherever we can get it, actually. Because I think it's important and I'm very curious. I don't know how much of the expenditures for this year, for 21 even, are related to all the deferred procedures and the deferred care right from 20, what that impact is, and how that impacted the really high prices in 21 and for this year as well, for 22.
Yeah, I think you make some really good points, Bobby, and it sounds like Margaret is doing some work internally, and what you're looking for is to take the slides that were presented today and hone in on our members specific to hospitalization and drug spend. Am I hearing you correctly?
Yes, and also the people who have spent, no spending, right, at all. Yes, you articulated that very well. Thank you, better than I did, certainly, but yes, thank you,
So
Valerie.
it sounds like, Margaret, you will take this back and ponder on how at maybe probably December might be a little bit too soon, but a January meeting, you can do some follow-up for Bobby and for all of us to show that that we are looking at our members and wanting to ensure that we understand some of the challenges that may impact their overall health.
Yeah, I do just want to caution about timing on that. We will certainly take this back and follow up. We are still and will be for the next several months in an extraordinarily busy time. In some respects, more busy than even the procurement time since April. But we hear the commission's desire here. We will take it back and think about a path forward that we can do for the commission.
Yeah, that would be great, Matt. And we know how much work everyone in the staff are doing. Maybe by the next meeting or the January meeting, you can register when you think you might be able to present that information to us so that we don't lose sight of the importance and the request. So even if it's in May or June of next year, you will let us know in December or January that you've registered it, you've talked to David and his team, and these are the the length of time you'll need. How does that sound for a commitment?
That's fair. We can certainly do that.
All right, great.
Yeah, I'd appreciate that. I was rethinking my comments that this is such an extraordinarily busy year, and I know between the procurements and the work that all your teams are doing, and then we immediately run into open enrollment, and that's a huge time. So maybe like by the end of the fiscal year, where there's a little breathing room, I just think that it would be, maybe by then we can have that information. I didn't mean to put any more pressure on, because I know what you'll be facing the next few months. So, maybe May or June is a better, time, or maybe during the summer, but
I think that's a great request, Bobby. Matt, we appreciate the flexibility in evaluating the request, and we look forward to hearing follow-up as soon as it's possible, just to let us know that you've heard this request. I know that gets Margaret excited from a data perspective anyway, so I see her nodding her head in excitement. Okay, not seeing any other business, and knowing it's getting to be the holidays and everyone's too busy with not enough time, I am going to suggest on final look that there are no other questions for other business. And at this point, then This concludes our November GIC meeting. It's adjourned. Have a wonderful Thanksgiving, and we will see you in December. Bye, everyone.
Bye, everyone. Have a great Thanksgiving.
Yeah, thanks,
Thank you.
Bobby,
Bye,
for the
everyone.
support today.
Thank you all.
Be well.